Transformation. My name is Anene Onyabo, and I'm a program manager in the Center for Health Information Technology and Innovative Care Delivery at the Maryland Healthcare Commission. MHCC is an independent regulatory agency whose mission is to, among other things, plan for health system needs and promote informed decision-making through a variety of initiatives. This includes supporting advanced primary care and practice transformation to shift the focus from quantity of care delivered to quality of care and improved outcomes and coordinated care delivery. During today's webinar, I'll share some key lessons learned for advanced care delivery from the Practice Transformation Network efforts in Maryland. You'll also learn about 2021 updates to the Merit-Based Incentive Payment System, also known as MIPS, and tips and resources for succeeding in MIPS, including data collection and submission options. Before we get started, I would like to cover a few housekeeping items. The webinar is being recorded and will be posted to MHCC's website. A copy of the slides will be emailed to all participants. In the event this webinar is breached, we ask everyone to please hang up immediately. I'll send a new meeting link to everyone who registered for the event with instructions for how to join the new meeting. Continuing medical education credit will be offered for this webinar. Please include your name in the chat box window to confirm and record your attendance, especially for those joining us by phone. Please include your name in the chat box so that we can record your attendance. I'll provide more information on how to get your CME credit at the end of this webinar. At this time, all webinar participants are muted to limit any background noise during the presentations. We will have a 10-minute question and answer session following the presentations. To ask a question, please raise your hand using the hand icon at the bottom of the screen. And if you're joining us online, there will also be an opportunity for questions for people joining us by phone. You may also include questions during the presentation within the chat box window, and I'll read this out loud to the presenters at the time of the Q&A session. You can unmute and mute yourself using the small button at the bottom of your screen that looks like a microphone, or by entering *6 if you're joining by phone. Please keep your line muted until you're ready to speak to avoid any unintentional background noise coming through. If you're having issues with the technology, please email, call, or text Kelly. Her contact information was included in the email sent yesterday. And Kelly, if you could please include your contact information in the chat box as well, that will be available to you as well. So I'll start the presentations with a background on the Practice Transformation Network efforts in Maryland. The Transforming Clinical Practice Initiative, or TCPI, was one of the largest federal investments uniquely designed to support clinician practices through nationwide collaborative and peer-based learning networks that facilitate large-scale practice transformation. The initiative ran from 2015 to 2019. TCPI grantees formed Practice Transformation Networks, or PTNs, to support primary care and specialty practices, and provided hands-on support to practices for developing skills and tools needed to improve care delivery and transition to alternative payment models. The Maryland Healthcare Commission, MedChi, the Maryland State Medical Society, and the University of Maryland School of Medicine Department of Family and Community Medicine partnered with the New Jersey Innovation Institute's Garden Practice Transformation Network in 2016. Using data to track quality improvement is key to practice transformation. PTN practices use the Practice Transformation Analytics dashboard to review data and identify areas where improvements could be made. 23% of practices improved on one quality measure, 15% on 2, 13% on 3, 19% improved on 4 quality measures, and 2% improved on 5. Some resources to help your practice use data to inform quality improvement are the TCPI Change Package and the AHRQ Quality Improvement page, which provides resources. Patient and family engagement, or PFE, is a key element to improve care quality, reduce errors, and empower patients to manage and control their own healthcare conditions. GPTN practices track their progress across 6 measures: support for patient and family voices, shared decision-making, patient activation, active e-tool, health literacy survey, and medication management. All practices met at least 2 PFE measures. Most practices met 4 of the PFE measures, and 11% met all 6. Some resources to help you support patient and family engagement efforts in your practice are the MHCC Patient and Family Advisory Council Guide for Ambulatory Practices, which includes resources to help create, integrate, and expand a patient and family advisory council, and the TCPI Compendium of Person and Family Engagement Tools and Resources. Providing coordinated care following discharge from a hospital or other healthcare facility can improve care and help prevent unnecessary readmissions. PTM practices provided varying levels of transitional care management. About 11% of practices made improvements in care planning and 28% in transitional care management. I want to highlight here a few resources that can support care coordination in your practice. AHRQ's webpage includes tools and resources to support and develop care coordination. Additionally, the MHCC has developed a care management capabilities and readiness assessment guide to help a practice determine care management preparedness, design a care management program, define a care manager's role in a practice, and identify leading care manager responsibilities. Increasing access to care can improve outcomes and lower cost. Some strategies to enhance access to care include using alternatives such as telehealth or e-visits, and providing patients with around-the-clock access to providers or the care team for advice about urgent and emergent care. PTN practices improved on providing enhanced access to care. About 81% of practices provided alternative care visit types, and an increase of about 72% from baseline. So here are some telehealth resources. The first is the Telehealth Readiness Assessment Tool, which assists small practices preparing to implement or scale telehealth services. The MHCC Virtual Resource Center offers information to providers on health IT adoption and use, with an emphasis on telehealth during the state of emergency. Available information includes educational flyers and other resources. Lastly, the Telehealth Implementation Program for Ambulatory Practices provides practices with virtual access to coaches to help guide telehealth implementation, including helping your practice complete a telehealth readiness assessment, providing consultation advice in selecting a telehealth solution, and collaborating with your practice to remap workflows. So this brings me to the end of my presentation. Next, I'll turn it over to Dr. Mingle. Thank you so much for joining us, Dr. Mingle.
Pleasure to be here. Thank you for inviting me. Let me see if I can switch. Oh, not yet. There we go. All right. I am Dr. Dan Mingle. I'm a family physician. I'm currently executive chairman and chief medical officer at Mingle Health. I've been a practicing physician. I've been residency faculty. I ran EHR implementation support for our community health system. And now I'm enjoying helping my peers. I went into business to try to provide for my colleagues those things I wished I'd had when I was in practice. We're here to help with the virtuous cycle of practice improvement, providing tools to engage patients, improve outcomes, measure results, submit those results to the stakeholders that want it, like Medicare, look ahead, prepare next steps, and then repeat. I'll be giving you some review of the quality payment program 2021 version based on the final rule that came out in December. Any changes in eligibility, performance category, the MIPS value pathway, and the web interface, and the new APM value pathway. Just as a matter of review, the quality payment program was queued by MACRA in 2015, MACRA legislation. Medicare considers alternative payment models to be the first pathway. And that first and second designation implies the priority they put on the programs. Alternative payment models are broken down further into advanced alternative payment models and what I call garden variety MIPS APMs. The MIPS APMs typically have an upside share. If you save money on your practice population, you share in that savings. The advanced APMs have a downside loss if you spend more than expected. The MIPS program, Medicare stages as preparing and encouraging people to go into APMs. It is now it's run on 4 performance categories listed there in the pie chart on the right. This year's balance is 40% quality, 20% cost, promoting interoperability at 25%, and improvement activities at 15%. Eligibility for 2021 has not changed in the last 2 years. Look for your clinical credentials here to know if you are part of the eligible list. Low volume exclusion and opting in have not changed. It includes if you bill more than $90,000 in allowable charges to your Medicare patients, see at least 200 Medicare patients, and generate at least 200 charge line items, you are eligible. You're excluded if any one of those is below the benchmark, and you can opt in if any one of those is above the benchmark. Special rules apply for MIPS if you're a low volume practice, as I just described. If you're a small practice, it's 15 or fewer providers. If you're not patient facing, if you're hospital based or ambulatory surgical center based, I won't go into the details of those special rules, but you can find your eligibility on Medicare's qpp.cms.gov site. As you log in, there's this NPI insert to check your status, or by signing into the program, you can check for your practice as a whole. There's typically 2 determination periods, the year prior to the measurement year and the first 3 quarters of the measurement year. If your status equals one of those in either of those periods, that's your status for the reporting period. Participation rates overall looking back at PQRS, they were steadily on the rise until we hit MIPS. The participation didn't fall really, at least not in the first year. They simply by instituting the low volume threshold, Medicare eliminated most of those people who weren't participating already. The second year, they pushed the low volume threshold even further and getting near 100% participation at this point. Performance, it's still a program where all the children are above average. Nearly everyone does well. Only 2% of participants were in the negative adjustment range in the most recent fully reported year of 2018. In those years, 84% were top performers, getting an exceptional performance bonus, and a full 97.55% were in the positive range. Now, don't expect that to be performance for years to come. I'll discuss some of the ways that they differentiate here. One of the first ways is the maximum amount you can gain or lose. We are now in the maximum that was cued by the legislation, although the Secretary of Health and Human Services does have a little leeway to go above this if need be. We expect it to be plus or minus 9% now going into the future. Now, remember, this is a performance year listed here. The performance in 2020 is like every year paid 2 years after that. So this will be 2022. We are now in the 2021 year being paid for our performance from 2019 and working on the submission that will pay in 2023. But the actual, you can actually lose 9% if you don't do anything. Typically, if you submit anything, you'll be above that. And again, it doesn't take much to get into the positive range, but this is a revenue neutral program. So you typically cannot earn that full plus 9% that they take from the losers and distribute to the winners. It's very dependent on how many people are in the losing pocket. Another way they adjust your experience every year is by changing these inflection points. There's a cliff at the bottom where the lowest 25% or lowest 15% lose the last 15% of the adjustment. Every score below 60 is in the negative range. At 60 is neutral. Everything above 60 is positive. The exceptional performance bonus kicks in this year at 85. This is the last scheduled year of the exceptional performance bonus, so we may not see that inflection in the future, although I think that's one of the things we may see legislation restore. Particularly with these last couple years that COVID has diminished participation. Over the years, the performance category weights have changed, and this bar graph shows you that. Cost started at 0 and has been gradually incrementing upward until next year's program will be at the design balance between cost and quality. That is required by law unless the legislation is changed. So expected to be 30 and 30 next year. Improvement activities remains at 15 and promoting interoperability at 25%. We expect those to remain the same through the life of the program. Data completeness criteria, that how much data do you need to submit in order to pass. Quality requires a full year of data covering all your payers for all the patients you see, and you have to submit data on 70% of your eligible cases. Any less than that, and you don't get credit for the submission. Cost requires a full year of data. Of course, Medicare calculates that. You don't submit anything for that. Improvement activities. Each improvement activity has its own specifications, which tells you how much you need to submit. Typically, the default is 90 days at least, and now 50% of your eligible clinicians, if you're in a group practice and submitting as a group, have to participate. Of course, if you participate alone, if you're making an individual submission, you have to perform the activity for 90 days to qualify. Promoting operability, we expect permanently to remain at least 90 days. I don't expect to see the standard requirement increase more than that. You can do 90 days or any amount of time beyond that. For quality measures for 2021, there are 209 measures. 11 have been removed since the 2020 year. Two administrative claims measures added. Administrative claims are measures that Medicare calculates from the claims data. They apply it if you're eligible. And those two new measures are hospital-wide readmissions and complications of total hip knee. 113 measures have changed, including some of the biggest changes. Hemoglobin A1C now has strata. If you're not in the highest level hemoglobin A1C, they're also looking at 2 lower levels as well. Depression screening has tighter specifications. So many of you will be using the same measures this year as you used last. Recognizing that 113 have changed, you need to review the specifications to be sure that you're recording the data you need to perform well on those measures. Specialty measures have changed a little bit, a few additions, a few subtractions, nothing tremendous there, but again, if you're depending on the specialty measure sets, be sure you review the changes in there. Improvement activities, one activity has been removed because its activity has come to an end. There is a new COVID-19 improvement activity that was introduced last year and continues indefinitely as far as I'm aware. That's had some clarifications. They've extended the call for activities time frame, so every year you can suggest activities between February 1st and June 30th. Because of the COVID emergency, they recognize the need to get Health and Human Services nominations anytime, so they declared that they would always accept recommendations from the department. They've also created some new criterion in preparation for the MIPS value pathway. They wanted to see new activities that can be linked to existing MIPS quality and cost measures. Promoting interoperability has one interesting change. The health information, there's a new health information exchange alternative. They previously had and continue to support receiving electronic referral information when you're receiving a patient, or sending electronic referral information directly when you're sending someone out. Now connecting to a regional health information exchange with two-way exchange also qualifies. So from either of those, you can get a total of 40 points. Everything else remains the same. There were some changes to certification standards triggered by the 21st Century Cures Act. Those changes, they didn't change the label of the standard. It's still a 2015 cert that's required. And that update to this 21st Century Cures Act has to be implemented by the end of 2022. Cost, no major changes there. They've gone through the list and made sure telehealth was reflected in all of that, but they didn't introduce any new episode measures, which started, what was that, 2 years ago now. I would expect to see some new episode measures introduced for next year. They have tightened audit rules. There's 2 levels of audits that Medicare requires. One, they expect their qualified registries to perform. So expect to be perhaps have a little more stringent rules coming from your registries. And then in some select cases, Medicare directly performs audits. Again, it may be focused for reason, or it may be random. MIPS value pathways we've heard about for a couple of years. We were expecting to see something introduced this year, but because of the COVID emergency, they've postponed for yet another year. We're expecting the first MIPS value pathway to be introduced this coming for this next performance year. A MIPS value pathway is a process of introducing or assigning existing quality measures, match them with a cost measure that's on the same subject matter, and as able to improvement activities. So you have a coordinated set around one topic. They could be an enormous change over several years, or may fizzle. Who knows? But expect they have they've outlined more process by which they'll be exploring and implementing these. And again, we may see some by this coming January. Talking a little bit about MIPS APMs, they've brought some more cohesiveness between the MIPS and the MIPS APMs. That is the garden variety APM, eliminating what they used to call the APM scoring standard. Now they've aligned it much more closely with MIPS. One of the biggest differences, though, is cost is addressed in the shared savings part of the program. So you only see the other three activities a little reweighted, as you see in the pie chart to the left. APMs considered advanced in 2021 are basically the same as they were in 2020, listed here, with the addition of Primary Care First, which the first cohort starts this year, and they're now recruiting for the second cohort. One of the biggest changes triggered in this last final rule was the announced web interface mechanism will be eliminated at the end of this reporting year. This shows the impact. The graph to the right shows the impact of that. In the PQRS years, web interface was the third most common used method. Claims was first until the final year. Registry took over the first place near the end. And then with a conversion to MIPS, web interface rocketed up to the top. It's it's the only remaining practical manual technique that you can do manual chart abstraction with. One of the reasons that Medicare is discontinuing it. They've also seen a drop off of use by large organizations. You have to have at least 25 providers in your practice to use that technique. But for whatever reason, it is expected to be discontinued after the final submission first quarter of next year. And for the 2022 year, you'll need to use one of the other methods, registry, EHR, or QCDR. Claims is nearly gone, and that's still under threat. That's maybe now about 6 years old that they were going to be ending the claims submission method. But as you can see, very few people are using that at this point. When the web interface submission method ends, which is used most by MIPS APMs, and other APMs, they'll be switching to an APM performance pathway, which is very similar to the concept of the MIPS value pathway. The APM is active for this year. It looks like this. In the blue box are the measures for submission of the APM, with the red box being the web interface. APM practices have a choice of using the web or the APP this year. Next year it'll be purely APP. These measures down here are being eliminated as you move from the web to the APP method. And that's all for me. Ask your questions as Anene described. And coming up next is Casey Fields from Clarent. Take it away, Casey.
Thank you so much, Dr. Mingle. Thank you for that informative presentation. Let me just pull up those slides for you, Casey. But before we go ahead, I wanted to also remind the folks over the phone. We have a couple of people over the phone, a number of people actually, who we don't know who they are. So if you could please include your information, your name, in the chat box, that would be greatly appreciated. A number ending in 77. We have a number ending in 02240 ending in 02. We have another number ending in 7024070. A number ending in 1030110. A number ending in 00. So the first three digits are 41000. Another number 443 ending in 35. Another number 804 ending in 00. So if those people could please send me an email with your name, just letting us know that you're attending this webinar, or just include, if you're able, your name in the chat box. We would greatly appreciate it. Over to you, Casey.
All right, thank you so much. I appreciate the opportunity, and great job with Dr. Mingle putting together all of that great information. It was really important, such at a high level. I think I may have wrote down a few things and learned some things. So again, thank you. So I'm Casey. I am with Clarent. I've been with Clarent for the past 4 years, and I am a part of the MACRA and SERS contract. So I'm responsible for providing technical assistance to eligible clinicians in the Maryland and District of Columbia area. And I've also worked on providing technical assistance for larger practices in the same region. And I also work with physicians on the PQRS platform, as Dr. Mingle had mentioned. So for now, I'll pass the ball to my colleague Charlotte and Charlotte Garlew, and let her introduce herself. So Charlotte, if you want to.
Sure. Thank you so much, Casey. And I think we can go to the next slide, please. So my name is Charlotte Garlew, and I'm also with Clarent, and I've been with Clarent for almost 10 years. I'm currently the project manager for the first contract, working with Casey, and we are supporting the eligible clinicians in Maryland and in the District of Columbia. I'm also working as a project lead for the Nursing Home Quality Initiative, and this covers Maryland, Delaware, and DC. This is part of the IPRO Quality Improvement Innovation Network, Quality Improvement Organization, also called QuINQ-IO, and we are currently in the 12th scope of work. I previously worked with utilization management contracts for Maryland Medicaid for almost 11 years. And my background is in nursing, and I graduated with a bachelor degree from the University of Copenhagen in Denmark in 1994. And I think Casey will take it from here. Thank you.
Sure. So Charlotte and I both work for Clarent. So with Clarent, we are subcontractors to iPro. In 2017, we were awarded a 5-year contract to provide technical assistance to the quality payment program in their eligible clinicians, specifically in the District of Columbia and Maryland area. So being the subcontractor, we currently work closely with our colleagues at iPro and other stakeholders, and we work closely with them to develop strategies and provide them with resources so all of the clinicians can be successful in this MIPS program. Next slide, please. Oh, I think I may have skipped a slide. I'm sorry, I keep forgetting to say next slide, thanks. So today we're gonna be discussing how Maryland clinicians will be able to locate and determine their eligibility status, participation options, and goals for MIPS in 2021. We will also talk about how you can identify a workflow for your practice, which includes data collection and submission options. And last but not least, how to access and navigate resources that are available to lessen provider burden. Next slide, please. So MIPS eligible clinicians. So there are a few ways you can be eligible for MIPS on the individual level. If you are reporting or being eligible as a part of a group, or if you are a part of an APM, and also a virtual participant. Typically, if you don't meet any of those requirements, you would be ineligible or exempt from MIPS, if you will. Next slide, please. So there are several ways that you could be eligible for MIPS. As Dr. Mingle mentioned earlier, at the NPI and 10 level. Another way is if you elect to opt in, and that would be because you meet just at least one of those 3 elements of that low volume threshold. If you choose that option, you would be considered then a eligible clinician for MIPS, and then you're subject to all of those requirements, right? Which is receiving a performance feedback report. You could be subject to a payment adjustment. So all of those things. And the final option would be if you voluntarily decided to report, which means you don't meet any of those requirements. However, you may just want to practice and prepare for any future eligibility requirements. Next slide, please. So practice goals. So at Clarent, Charlotte and I and our team, we have, within our experience, come up with some suggestions that we think would be really good strategies to help you be successful. You know, because everyone's practices and whatever your situation is could be at a different level. So one, creating a consistent workflow for your practice, which could mean implementing a strategic business plan, as I mentioned, whatever's conducive to your environment, whatever that looks like for you. It's different for everyone. So deciding if you're going to maximize your efforts on MIPS, if you want to go above and beyond and go for that incentive, or if you just want to do the bare minimum just to avoid that negative penalty or payment adjustment. So those are important details that you need to make a decision on. And then also creating a HARP account and also deciding which reporting method you want to use for your submission of any measures that you choose. So all of those things are really important. And also to keep in mind, when creating a HARP account, you want to make sure your credentials are aligned with, I guess, for lack of better terms, the credentials that is accessible to any of the staff there, meaning, or an example, if you have a practice manager is an administrative assistant and they decide to leave or they're new, they want to have access to this information. You know, it may not always be the clinician that uses their information. So that's also important. Another thing is establishing relationships with your stakeholders and vendors. Another example is if you have an EHR system and whatever vendor you choose, if something goes wrong or they have configuration issues or they have updates or CMS requires a new certification, all of those things, any of those scenarios, it would be great to have a direct contact to be able to reach out to someone and say, hey, this isn't going well, what should I do? That's really a good suggestion. And last but not least, choosing measures that are applicable to your practice. We often see here at Clarent that some physicians, they may be like overwhelmed with this new program or just getting into it. They may be newly eligible and they look at all the measures, as Dr. Mingle mentioned earlier, there were actually more. So right now, it would be best to look at measures that are applicable to your practice. In most cases, you're already doing them. You're already practicing these things. So that's really important. Next slide. Well, I think I'm finished until later. So I'm gonna pass the ball back to Charlotte to continue.
Okay, well, thank you so much, Casey. So let's talk about some more specific ways that you can be successful in the MIPS program. And if you have not participated in the MIPS program before and you're new to this program, it's important to start now. It is not too late to start the conversation and to talk about what and who will be involved in this process. It's important to take a close look at your daily routines and your processes for your practice and your specialty, and to talk about what you're already doing that could potentially become part of your data collection. So I'll give an example. If you decide to include screening for depression and a follow-up plan, and you want to include that as one of your quality measures, you might want to ask the front desk staff or receptionist to hand out a screening tool to the patient when they first arrive and check into your practice. You may want to include the BMI screening tool or the BMI screening as one of your 6 quality measures. And that way you may have to involve the nurse or someone else who records the height and the weight of the patient in their chart. So basically, you want to make sure you involve all of your staff and that you communicate on a regular basis. This could just be like a quick 15-minute meeting every week, a little huddle where you go over any challenges or barriers, or maybe you just talk about what really works well. So the key thing really is to remember to include everyone on your team and to communicate often. And once you have your workflows established and perfected, you also want to follow up and check on your remittance advice or eligibility of benefits notices, also called RAEOB. And I will come back to this in a little bit. So for now, let's go to the next slide, please. Okay, on this slide, I know this can be a little bit hard to see this form, but let's talk about the Medicare Part B claims form. This is for the clinicians that choose not to or do not have an EHR system or choose not to use a registry to submit their data. A lot of smaller practices that we have worked with here at Clarent, when I say smaller practices, it's single practitioners, or maybe they have only 2 clinicians in their practice. A lot of them don't have EHR systems, and they don't have the financial availability to actually invest in it. So they can use their Part B claims forms to submit codes for their quality measures. So that's why I just wanted to go over this form just in a little more detail so that you can give you a few highlights on what's important when you do fill out this Medicare Part B claims form. So when you fill out this form, it is very important that you put in the correct diagnosis. And the diagnosis is entered in field number 21A. And again, I know it's hard to see this form, but 21A is where your correct diagnosis has to be entered. And this is important because when you do want to report on a quality measure, the corresponding G code or QDC code has to match up with the diagnosis. And I'll come back to this in a minute. But let's take an example. If you, for example, see a patient and that patient has a diagnosis of age-related macular degeneration, the diagnosis code will be entered in field 21, line A. On line number 1, which is where you will fill in the date of the encounter, of the date of the visit, you also want to put in the code for the office visit on line number 1, and you want to put in or enter a charge for the visit. So basically, line number A is just filled out as a regular office visit. Now, let's say that clinician wants to report on a quality measure that is related to the diagnosis that you entered in field 21A. You will find that you have to put your QDC or G code on the next line, line number 2. So on line number 2, you will fill in the same date for the visit. You will fill in the code, the QDC or G code on line 2 for the quality measure that you're reporting on. And then you also want to fill in a charge. Now the charge can be either a 0-cent charge or a 1-cent charge. And I'll come back to this on the next slide. But important to remember here is whichever diagnosis you enter must correspond to your G code or QDC code for the quality measure that you are reporting on. Okay, the QDC and the G codes can be found on in a specification document for each of your quality measures. The specification documents are listed on the qpp.cms.gov website. At the end of the presentation, we have a slide with all the resources. And when you go to this qpp.cms.gov website, you can explore the quality measures and all the specifications. And for each of your quality measures, there is a document that specifies all your QDC/G codes. Okay, let's go to the next slide, please. So the remittance advice and your EOB, eligibility of benefits notices. Again, as you remember, I was talking about a 0-cent charge and a 1-cent charge when you enter your codes, when you report on your quality measures. So when you receive your remittance advice or EOB notice, it will list denial codes. And these denial codes correspond to the information that you submitted on the claims form. So depending on whether you entered a 0-cent charge or a 1-cent charge, you will receive different codes. Pay attention to the codes, because if you entered a 0-cent charge for your for the code for your quality measure, N620 will be listed as a denial code. What this tells you is that the QDC or G code that you entered for your quality measure is a valid code for 2021 MIPS performance year. So if you see this code, you know that your QDC or G code is a valid code. If you entered a 1-cent charge, you will see a denial code of CO246 N620, and again, it tells you that this QDC code that you entered is valid for 2021. Again, it's important to keep track of all these RA EOB notices from your Medicare administrator contractor, and because this will help you keep an eye on how well you are performing in the quality category. Okay, let's move to the next slide, please. So we'll do a little, go over a little case study. A couple of years ago, we were helping a small family a clinician in a small family practice. We'll call him Dr. B. He is a single clinician. He's an older doctor. He works with one administrative assistant, Ms. R, and she's responsible for all the billing. And she's also responsible for appointments and amongst many other things. So Dr. B does not have an electronic health record system. Like I said, he's an older clinician. He does not want to invest in one. All his patients' medical records or paper records. And at the beginning of the performance year, and I believe it was in 2018, we helped him identify 6 quality measures that would align well with what he's already doing day to day. And again, since he didn't have a EHR system, he would have to report his quality measures via his Part B, Medicare Part B claims form. Each of the 6 quality measures has a corresponding QDC code, G code, as I mentioned before, and these codes were added to the Medicare Part B claims form by Ms. R. Next slide, please. So the tricky part is how does Ms. R know which quality measures to enter on the claims form? So what Dr. B and Ms. R developed was a very simple, but very efficient workflow for communicating these quality measures for each of the patients. So after each patient visit, Dr. B was writing all the applicable quality measures on a little sticky note, and he was attaching it to the patient chart. It could be a yellow sticky note for the BMI quality measure, or a pink sticky note for measuring high blood pressure, and so forth. I think you get my point. And that way, when Ms. R was doing her billing, she would compare these quality measures written on the little sticky notes with a little cheat sheet that she had put together also at the beginning of the year. And this little cheat sheet had all the corresponding QDC and G codes. And this was an easy way for her to identify which quality measures she should put on the Medicare Part B claims form and report for each of these patients. Let's go to the next slide, please. So on this next slide, I just wanted to show you an example of one of the very common quality measures. It's called documentation of current medication, number 130. I listed the description of this measure. It's pretty straightforward, and you can see that the denominator and the numerators are listed as well. What I want to have you pay attention to here is every time when you choose a quality measure, it's very important for you to read the description carefully. For example, for this description, it's not enough to just list the current medication for the patient. You also have to list the dose, the frequency, and the route of the medication. And this is important in case CMS comes back and wants to do an audit. So just wanted to make you aware of that and make sure you pay attention to these descriptions. And the next slide, please. Okay, I think Casey, you will talk a little bit about special statuses.
I will. Thank you so much. That was really important information. Now, after going after you guys, I feel like I have like the get out of jail free cards. That's important stuff. So special statuses. So with the quality payment program, there are all automatic special statuses that applies to MIPS eligible clinicians. So if you receive a special status, you are your reporting requirements can be affected. So in some circumstances, in this case would include ambulatory surgical centers, hospital-based clinicians, non-patient facing clinicians, and small and rural practices. Next slide, please. All right, so CMS offers some exception applications, and they have two as of 2021. And CMS understands that there could be some burdensome, there could be some circumstances where it can make it difficult for you to report successfully on MIPS. So one of those exception applications is called the Extreme and Uncontrollable Circumstance application, which allows you to request reweighting for any or all of the performance categories under MIPS. Just in case you encounter an uncontrollable circumstance such as COVID-19. I'm pretty sure no one's never heard of that. Another exception application is the PI hardship application, promoting interoperability. So as of 2021, practices are required to have a 2015 certified EHR system. And that's under the promoting interoperability exception application. And just in case you don't have that, you may be eligible to submit one of these applications. Some other criteria would be just if you're a small practice, you can apply for this. If your internet connectivity isn't working properly because you're in a rural area, or if you face one of those uncontrollable circumstances such as COVID, you should be able to apply for some of these circumstances, and your score or however you performed in these categories or the points that you've achieved or not could be reweighted, and they could be acknowledged in another form or another performance category. So if you choose to apply for these, I'm not going to even say choose, because some of these circumstances are automatically applied to your HARP account or your eligibility profile that's under that QPP website, which Dr. Mingle went over earlier. So sometimes you can go there and you can see if these circumstances or exceptions are applied to your practice. So moving forward, both of those exceptions, if you do apply, you want to see if you are approved, it would be also in that same profile. CMS will send you a direct email to see if you are eligible or you meet the criteria, and then they will move accordingly to see if they can allow you to reweight your performance categories in those points. And I think that is all for me. So I think I'm going to turn it back over to Charlotte. I'm not sure. I think she's going to provide some resources that we have that you can reach out to us if you have any questions on like the local level, or if you're a small practice and you feel like you just have so many questions, all of this isn't making sense to you. So we're here for you. So I'll turn the ball back to Charlotte, and Charlotte will share some resources with you. Thank you.
Yeah, and in the interest of time, thank you, Casey. I'll just leave this slide up for a little bit, but what I wanted to point your attention to is iPro /Clarent, we do office hours, and this is on a bi-weekly basis. So every other Tuesday between 12 noon and 1 p.m. we have an office hour, and there's no set agenda for this for these office hours. Anybody who calls in can ask questions either via chat or via the phone, and subject matter experts will be happy to answer any of your questions. So I know we just had one this past Tuesday, so the next office hour will be in 2 weeks, I think on the 27th of April. So this is the link where you can go in and actually find the information for the office hours. But like Casey said, please reach out to us with any questions. We are here to support you, and our services are free of charge. So thank you so much, everyone.
Thank you both, Charlotte and Casey, for that informative presentation. We will now move to our question and answer session. If you have a question at this time, you can unmute and ask your question to our presenters.
We can open it up to the phone as well, too, Anena, for people.
And those on the phone as well. Thank you, Melanie. All right, so we have a question for Dr. Mingle. I know the max penalty is 9%. If I meet some, but not all the requirements, for example, not all the quality measures, am I correct to assume that the penalty would be significantly smaller?
Yes, that is correct. So it's submit anything you have. Every little bit takes away from the penalty. You may have learned in the PQRS that it was an all or none kind of a thing, but that's not the way MIPS work.
Thank you so much, Dr. Mingle, for that answer. We have a question for Charlotte and Casey. How many patients are needed for data completeness? Charlotte and Casey?
Yes, Casey, do you want me to?
Sure, you can. We can both answer. I don't know. You can start it off.
Yeah. Yeah. So for smaller practices, there is a minimum of 20 patients for your quality measures. Again, to really maximize your score for each of the quality measures, it should be 70% of your eligible eligible patients. But to really get just a minimum number for a minimum point for your quality measure, a minimum of 20 cases, patient cases, should be submitted.
And I'll just add that typically the physicians or the clinicians are already providing these services. So sometimes practices hone in and focus on how many patients, and then after they get over that, that initial feeling or I don't know, excitement or I don't know. They're probably already doing these things and providing these services and already have these patients that apply to these measures. So sometimes it's overwhelming because we have a deadline and we want to meet all the requirements. But if you look back and you have a platform in place where you can submit all of these measures, you're probably already doing it. You probably already have the patients. So that's all.
Thank you so much for that, Casey. So we are about at a minute to go, but I just want to throw one more question out there to Dr. Mingle. So Dr. Mingo, how do you select the right measures for your practice? And just keep in mind our time, please.
Yeah, well, there's two criteria. One, that it's applicable to your practice. Are you doing providing the service? And second, how do you think you're performing? And are you? Oh, a third factor, always three. Are you recording the data that you need to qualify for the measure? A good starting point is to look at Medicare specialty measure sets.
Right. Thank you so much, Dr. Mingo. That's really helpful. So we're right at the end of the hour with a minute to go, and I want to be respectful of everybody's time. Thank you so much for attending today's Advanced in Practice Transformation Lunch and Learn webinar. We hope you found the information valuable. If you have additional questions you didn't get to ask, please feel free to email them to me. We will be sure to convey them to our presenters. As a reminder, a copy of the webinar slides will be emailed to everyone. We also want to remind those over the phone to please send me an email with your name so we can record your attendance for this webinar. In the email we sent to you with the webinar slides, you will find a very brief post-webinar questionnaire. We ask that you please take a couple of minutes to complete the questionnaire, which will include information about obtaining CME credits for the webinar. Your responses are really helpful for us and inform future webinar and learning events. We're also interested in hearing from you regarding topics that would be of interest for future Lunch and Learn webinars. And that's it. Thank you so much for attending today's webinar. Have a wonderful afternoon, everyone. Bye-bye.
Thank you. Bye-bye.
Thanks, bye.